everybody, and thank you for joining us today. I want to thank Global Sepsis Alliance and our sponsors for making this event possible and make it possible for free. We have a terrific session today titled The Voices of Patients in Advocacy, Research, and Beyond. And I think, we've been hearing a lot so far in this conference and generally about, the big numbers around sepsis, 50 million, 11 million, 2 million in the US, 350,000 dying. But numbers kind of don't connect with people in the way that people's stories do. And, sepsis is really about real people and families being impacted. And it's these real people who can drive change in awareness, in delivering a more robust government response, and in supporting research and innovation. So I'm really happy that we have this session today to remind us all about the power of patients, whether it's in advocacy research or other things. My name is Tom Heymann. I'm the president and CEO of Sepsis Alliance. We are a patient advocacy organization based in the U.S., started after the death of a young child in 2002, which started our organization. And we work in 4 areas. One is public education, making sure the public knows sepsis is a medical emergency like stroke or heart attack. We also provide a support community for survivors and family members called Sepsis Alliance Connect. We also train healthcare professionals. We've trained over 60,000 healthcare professionals to be better equipped and better aware to look for sepsis and be able to diagnose and treat it more effectively. And then we also work in policy and advocacy, leveraging your voices and the voices of others to make sure that we're being heard in state and federal government about how large a problem this is for the government, for the nation in terms of expense and lives saved and torn apart. And then also innovation. What can we do as a patient advocacy organization to help industry bring better innovations to market and to the bedside, from brain to bedside? One of the things we're most proud of was that in 2010, Sepsis Alliance joined with 3 other organizations to form the Global Sepsis Alliance, realizing that sepsis was not a national issue, it's a global issue and does not obey borders. So really, really proud of the work that Global Sepsis Alliance has done and continues to do, and supporting kind of a drive to make sure that sepsis is noted and understood and addressed on a global scale. So I'm going to introduce our panel one at a time, and we have a fantastic panel today, and I'm going to provide brief introductions and then allow them to give more of an introduction, and I encourage all of you to look at their full bios and check out the work that they're doing in greater detail, which is all on the website. I'm going to start with James Hospedales. Forgive my pronunciation. James is a citizen of Trinidad and Tobago with 30 years experience in public health in the Caribbean, Latin America, UK, and USA. In 2020, he founded Earth Medic and Earth Nurse Foundation for Planetary Health to mobilize health professionals to address the climate crisis. Critically important. He has contributed over 100 papers and reports and is a regular contributor to the G7 and the G20. He's an honors graduate in medicine from UWI, graduate of London School of Hygiene and Tropical Medicine. And with that, I'm going to turn it over to James.
Thank you very much, Tom. Good morning, good afternoon, wherever folks are. Thanks for asking me to speak at this conference. It's kind of weird bringing a patient experience, and I'm a physician, but even physicians get sick, huh? So in 2021, I was admitted to hospital, unknown what the diagnosis was. Now, because of this conference, you know that it was sepsis, but at the time I did not know that. I just was sick. Okay, so in the next few minutes, I'll give you a short story of my admission to New York Langone Hospital in Long Island in 2021. I went on holiday. I did not go expecting to spend 2 weeks in a US hospital. This is the timeline. I traveled from New York to Trinidad at the end of August and developed non-specific symptoms shortly after. I was admitted twice to hospital and treated. The first time, the actual cause of the problem was not diagnosed definitively until I was discharged from hospital. It was leptospirosis. And I was admitted a second time for query stroke, query Bell's palsy. I'm happy to say a few days after that, I was able to co-chair a big conference on climate and health. So I had made a pretty good recovery, although I was very weak. I traveled from Trinidad to New York, and in those days, you had to have a COVID negative test pre-travel. And shortly after I got to New York, I was staying at my daughter's house. you see the history that would be, with hindsight, I realized what was going on. The headache, the systemic problems, the mood changes. My wife actually first noticed this. She said, "You've become very grumpy, uh, and you're not thinking clear." And then the vomiting and the fever and the chills and the rigors. And I took 48 hours to get into the hospital because they said, "Oh, you need a COVID negative test." And at the end, I was unable to sit up. There were two environmental exposures of note. One was gardening barefooted in Trinidad in very wet conditions. We had a very wet season. And also there were floods in New York, just as I had arrived in New York, but I had not been exposed to those. Examination and admission, low blood pressure, rapid pulse. I could not stand unaided, though I could hold a conversation. And I took a little notebook out and wrote down the names of everybody I met. And in 2 weeks, I met nearly 100 staff at this hospital. Initially, I was admitted to an isolation room because they weren't sure what was going on, except that it was infectious. Initial test results showed what you see here, low hemoglobin, a white account marked with neutrophilia. And I highlighted this because the physicians wanted to find some strange viral cause to my illness. And I had to say to the infectious disease docs, "Tell me what aspect of a viral disease is going to give you this differential on your white count." So I was a difficult patient. I kept questioning things. And I noted very high-tech health in the US. You get the test results on the phone often before the doctors do, which is interesting and could provoke anxiety among some patients, perhaps. But I was very happy to get my results quick. And the second day, this was on my chart, and I was in shock. Psychological shock to see sepsis with acute renal failure without shock. That kind of scared me. Although I was so sick, I had a little emotional reaction. My family was more scared than me. And the differential was viral. I had just come from the tropics, so could this be severe dengue? Could it be leptospirosis? And leptospirosis was assumed to be the working diagnosis, and was started on treatment, in particular antibiotics, which is what saved my life, really, and the importance of starting antibiotics early with suspected sepsis. Even if you think it's dengue hemorrhagic fever, start the antibiotics. That's one of my messages. During the admission, I went down a number of rabbit holes. I mentioned one. Is this some viral tropical disease? Ophthalmology came to see me because I had a pain in my eye, and they recommended an electroencephalogram, and I said, "No, I don't see any reason for this." And a question of a culture negative endocarditis was raised, actually by my son-in-law, and that led to an MRI, and then they recommended this transesophageal echo, and I said, "Nope, I don't think that's indicated. I don't have a murmur. I don't have any problems with my heart. Thank you very much." So on reflection, this was a real serious episode and a wake-up call. I lost a lot of weight. Treatment with antibiotics early in sepsis is important. Beware of rabbit holes. And I want to say something about leptospirosis. It's not only in rats. Don't be afraid to ask about diagnostic and treatment procedures that are proposed, and some other things that I noted while I was there. I also became very, when you're in the hospital, never mind you're a physician, you're at the mercy of the nurses. So I made a song, "Abandon your pride, abandon your dignity, obey the nurses, obey the PT." That's the physiotherapist. Because if you don't obey them, they can make your life miserable. And if you do obey them, they can treat you very nicely. Now, this little creature, I wonder how many people recognize this. This is about 10 centimeters across. This is a Bufo marinus. It's a large tropical toad. Our lawn had plenty of these before I got sick, and I was out, as I said, gardening barefooted. And maybe this is, they're well known to have leptospiras. All vertebrate species can have leptospiras. So my family gave me a pair of waterproof gardening shoes, for which I thank them. And I mostly wear it if I'm out in the garden. And then the last person I have to thank, would you believe that this guy started the sepsis program at the hospital at which I was treated about 10 years before I was admitted? And if you don't know him, he's president of the Global Sepsis Alliance, and a graduate of University of West Indies. Thank you very much.
James, that's fantastic. And yeah, I think many of us owe a lot to Tex Kassoon. Terrific story and so powerful to have a clinician sharing that story and really, exposing a lot of the things that could have gone better. If they had suspected sepsis initially, given how common it is, perhaps your journey would not have been so challenging. So a lot to share there. Thank you for that. Thank you for the song also. Really appreciate that. Okay, next we're going to go to Elena Moya. Elena is a survivor of meningococcal meningitis, which she contracted at the age of 4. She fully recovered thanks to seeking medical help on time. Since her experience, she has been very concerned about this disease, and for the rest of her life, Elena has committed to work to tell other families about the disease, to know to get their children vaccinated, and to know to rush to the closest hospital as soon as they may recognize the symptoms. Her latest major work was contributing to the World Health Organization launch of a roadmap to defeat meningitis by 2030. Thank you, Elena. I'll turn it over to you.
Thank you very much to the organizers for the invitation. It's really an honor to represent today in such important Congress patients' organizations, families, and patients that have suffered and are currently facing the after effects of this disease in Europe. I will share with all of you what a group of patients can do when turning pain into action. For the first time in Europe, we named Sepsis Stronger Together, organized exactly 7 months ago an event in the beautiful city of Paris. We called it Revealing the Burden of Sepsis for Patients and Their Families. This initiative was launched by patients themselves and patient associations like Sepsibel, Stop Sepsis, Sepsis Tinfun, Asociación Española contra la Meningitis y Sepsis, Sepsis Andarna, Sepsis Foringen, Global Sepsis Alliance, European Sepsis Alliance, the UK Sepsis Trust, the Irish Sepsis Foundation, and France Sepsis Association. Let us thank the support we receive from FHU Sepsis and CERM, Hôpitaux de Paris, Comprehensive Sepsis Center, and Université de Paris-Saclay. We were so fortunate to be able to organize inside the Palais de Iéna. Our program was aimed at raising awareness of this disease, give visibility to patients, share experiences of aftercare for families, and talk about long sepsis. We were also very lucky to listen to Professor Jilali Anand, and the title of his conference was Sepsis, the Unknown Killer. Some interesting and updated data shown that sepsis awareness in Europe is unequally extended. For instance, in Germany and the UK, they show great knowledge compared to Spain, France, or the Netherlands, where there are no plans yet or national plans. The most heartfelt part of this day was, without a doubt, listening to true stories of survivors or affected families. Let me finish with our most relevant outcome, the Paris Declaration of EU sepsis patients and families, which represent a unique call to action for EU public health authorities, and the publication of our initiative in the online journal, The Lancet. I'm looking forward to the discussion to be able to share with you more details of this initiative. Many thanks for your attention.
Thank you, Elena. Fantastic work. I'm going to turn now to Priskil Hmar. I hope I'm pronouncing that correctly. Priskil earned her master's degree in economics. She got sepsis in April 2014 when she was just 19 years old. And she also suffered heart failure and kidney failure as a result. She was admitted to CCU for months, ventilated, and by the grace of God, in her words, and with the hand of her medical team, she survived sepsis and has a story to tell and inform and help others. Priskil, I'll turn it over to you.
Hello, everyone. Thank you to all the organizers. My name is Priskil Hmar from Mizoram, India, and I have suffered from a severe systemic lupus erythematosus. followed by sepsis with multiple organ system involvement. I was on a ventilator with multiple vasopressor, vasopressor support and hemodialytic support. Some uncertainties in myself and families remain whether I will recover or not. I really work hard, and it's very tough situation to fight that sepsis disease. So, but I never lose my faith and my confidence financially. My family was also very supportive. Best part, I always remain comfortable is the support I received from the medical team and family was excellent. And then I want to share some my success story that I have suffered this disease almost a half year, and I stayed in the critical care unit for around 4 weeks, and I stayed in the hospital for 12 weeks. But thanks to God and doctors, and I have received so much prayers. So because of that, I'm able to reach this level and the desire to be well. I think the voice of patient, our voice is very important to everybody who was suffering for sepsis, that we should not give up. We should try our best to fight these diseases. Um, and we should pray to, yes, we are Christian. We always say that as the name of God. We used to pray, we pray very much. And along with that, by the hands of doctor, I can be sitting here till this level. So I want to share all of my story, success story, along with my difficulties, faces, impact. So thank you.
Thank you so much, Priskil. And you know, the theme you bring up about the benefit, the need of community, whether it be from your medical team and or your family or your faith, we see that as themes of folks who do better generally talk about having that support system. And many of those who struggle don't have that support system, whether their medical community doesn't really take what they're experiencing seriously. And it really can make a huge difference. So thank you for sharing that. And we'll get back to you. I'm going to turn next to Graham Segars. Graham is a passionate environmental advocate, researcher, and sepsis survivor dedicated to creating meaningful change. His journey took a profound turn when he was diagnosed with septic arthritis, which developed into life-threatening sepsis. This life-altering experience shaped his mission to raise awareness about sepsis and inspire action to combat this global health challenge. Through his work with the Global Sepsis Alliance, Graham combines his personal story of resilience with his professional expertise to advocate for better awareness and prevention strategies. It's great. Turn it over to you, Graham.
Hey, yeah, thank you, Tom. I also wanted to thank the Global Sepsis Alliance for allowing me to be here today. It's a true honor to be able to share my story with everyone. So just a little bit more about me. Like Tom said, I'm an environmental science student at Wofford College, a small private institute in South Carolina. So I'm a senior this year, so I kind of I've been trying to, get my stuff together. Long story short, well, unfortunately, on Thursday, July 25th, I heard a pop in my hip. I started my shift at 8 a.m. and during my 10:30 break, whenever I go back home, I kind of work seasonally at a local fast food joint. And so during my 10:30 break, I stepped out of my car and suddenly felt a pop in my right hip. I thought it was a pulled muscle from overuse. I had been on a weight loss journey doing the Stairmaster almost daily, so it made sense at the time. But the pain got worse, and as I tried to push through and finish my shift, but within an hour, I could barely walk. I begged my manager to let me go home. I had to drive using one hand to lift my leg and the other to steer. When I got home, my mom met me at the bottom of the stairs and helped me get to bed. So that night, I had chills, intense pain, and could feel something was deeply wrong. So the following day, Friday, July 26th, was the first doctor's visit at my local hospital called Lexington Medical Center, urgent care. And so I went to the urgent care, and my mom wheeled me in the urgent care while I was in a wheelchair. The nurse practitioner never asked me to remove my pants and didn't even examine my hip, didn't order an x-ray or anything of the sort. She said it was a pulled muscle, sent me home with some ibuprofen and said I'd be good in 2 to 3 days. Well, I'd been waiting all summer to go on a trip to New York, actually. And I told her I have a trip to New York this coming Tuesday. Do you think I'll still be good to go? And she said I'd be fine. So Tuesday, July 30th comes around and I fly to New York City, still in serious pain. I didn't want to miss the vacation because I'd been looking forward to it all summer, like I said. And I went to the airport with crutches, but I quickly realized that I needed a wheelchair. I was immobile, basically. I was wheeled through the airport, boarded my flight, and landed at LaGuardia, still unable to walk. I tried crutching around the city, but after a little bit, I had to climb 5 flights of stairs to walk up to my friend's apartment, in the apartment building. And I knew something was wrong when I was struggling so much to even do that. So Wednesday, July 31st, I decided it was the following day. I decided that I was not okay. I needed to go to the doctor. There's something wrong with my hip. This is not just a pulled muscle. So I got an appointment, like a MedMD, just a local urgent care, and they took an x-ray, didn't see anything, and referred me to an orthopedist. I didn't feel comfortable navigating the new specialist in the city because I am still young. And so I changed my flight to return to South Carolina just a little bit earlier. So I got home on Friday, August 2nd, and on Saturday, August 3rd, I had an appointment with Prisma Health Orthopedic Urgent Care where they scheduled an MRI for Friday, August 9th, and the pain was unbearable, so bad to this point where I could barely even move it, sharp stabbing pain. And I kind of felt it a little bit like, go to my butt a little bit because whenever I sit down, the arthritis would move around. So it was just my entire right leg. My right side was below the waist, so my right side was just terrible. So Friday, August 9th, I went to receive the MRI that morning, and we were told we'd hear back later that afternoon, but the phone never rang. My mom called back, and the office had told us they had no record of the MRI even happening. The doctor told us in his 12 years of practicing there, this had never happened. Well, just my luck, this happens. Thankfully, the next day, they were able to recover the MRI images, and it showed arthritis in my right hip, and surgery was scheduled for Monday, August 12th to remove that arthritis. Monday, August 12th comes around, surgery happens. So I go in that morning, get the surgery done, get the arthritis removed, and they send it in for testing. And later that afternoon, I got called back saying it came back to be septic. We were told to go to the hospital immediately. So at this point, it's been about like 3 weeks since my leg initially started hurting. So I was hospitalized at Prisma Health Baptist, where I was given oxycodone and morphine to manage the pain. The infection had already eaten through my cartilage in my hip, and I underwent a second procedure and was hospitalized for 5 days. I was diagnosed with septic arthritis and a staph infection in my bloodstream. To this day, no doctor knows how I got arthritis or how the staph infection started. I kept thinking maybe it was tied to the Stairmaster and weight loss journey I'd been on, but the doctor told me that that wasn't the exact cause. During my hospital stay, I entered mild septic shock, and I learned how lucky I was because not everyone survives that. I had no prior clue what sepsis was, no information at all, knowing just what this disease was, what this infectious disease was in general. So I was very confused at the time. So recovery at home, I was discharged with a PICC line and placed on daily IV antibiotics for 3 months. Recovery timelines range wildly. Some doctors said 2 weeks, others said a year. At home, I had physical therapy twice a week, and a nurse came weekly to take blood samples for monitoring. All I wanted to do was go back to school and graduate on time. I had to fight my school for accommodations, being a small private institution in South Carolina. I had to argue with all the deans and even the president of the college to help get a Zoom accommodation just to get that accommodation approved. I missed 2 lab courses, so I'm currently taking 3 labs this semester just to catch up and stay on track to graduate. One big thing that I did realize once I got back up on my feet and everything, I began kind of getting a lot of judgments from strangers. I would walk around with just one crutch because I didn't want to look like an old man with a cane. So I would walk around with one crutch and everybody would have a comment to say about it. Like, you don't need that. Why do you have a crutch? You look fine. And so I come here today not only to advocate for sepsis, but just invisible disabilities in general, because they aren't well enough. Awareness isn't spread well enough for that. So long story short, after about 3 months of recovery, 2 to 3 months, September 30th, I returned back to campus. And funny enough, Hurricane Helene, Spartanburg, South Carolina is right in the path of Hurricane Helene, and Hurricane Helene had destroyed our campus so much that they had to send everybody home again. So I got there just to have to go back home. Anyways, that's beside the point. I went to physical therapy some more when I got back to school. And after a few more appointments, I was released, and it took about 3 month total recovery time. So today my right leg is still slightly shorter than my left, and I still get flare-ups if I'm on my feet for too long. But I'm incredibly grateful. This could have turned out way worse. I could not be here today telling my story, but I knew I needed to turn my story into something more. So that's why I appreciate the Global Sepsis Alliance letting me come here and speak today. So thank you, everyone.
Thank you, Graham. And a real reminder that, a lot of, I think, misconception around sepsis is that it only impacts older folks. And that is clearly not true. And the fact that it can present in so many different ways, really puts a focus on education and training of our healthcare professionals. Thank you, Graham. I'm going to turn it over to Robyn. Robyn Hayes Badenhorst. Robyn has over 25 years of experience working to improve healthcare access and outcomes, particularly in resource-limited settings. In her role as Executive Director of Supporting Health Initiatives, Robyn works with funders and partners to implement programs that strengthen healthcare systems and improve access to essential medicines. Her work is contributing to milestones like the establishment of the African Medicines Agency and efforts to enhance regulatory frameworks. Robyn is committed to promoting health equity and sustainable solutions that address both immediate and long-term healthcare challenges. Over to you, Robyn.
Thank you, Tom. And thanks very much to the Global Sepsis Alliance. So my journey began in 2023, when I lost my father to sepsis and stood by him for 6 hours it took to take for his organs to shut down. And it was the most traumatic experience I have had in my life. It was absolutely horrific. And I reached out to Miriam, Dr. Miriam Jashi, and said to her that I am up for sepsis advocacy. This is absolutely horrific. It was a medical term, and it had become a monstrous reality in my life, and I wanted to do something about it. So I'm going to speak from the heart today. I have a few words, and I'm going to use this platform to advocate for sepsis, specifically here in Africa, also globally. And you'll hear me repeat numbers: 11 million lives lost each year, more than HIV, malaria, and breast cancer combined. But for me, this is not just a number. It's sepsis stole my father's life, and swiftly, before we even knew what was happening. And his story is one of millions across Africa. So today, I want to raise my voice and our voices, not in grief, but in determination. So the African reality, as you've heard and you'll hear over the course of this evening and probably tomorrow, is that in sub-Saharan Africa, sepsis is a daily crisis. And we have over 17 million cases and up to 4 million deaths each year. And it's often the final pathway to or of preventable infections in newborns, mothers, accident victims, and even something as simple as stepping on a thorn. So a teeny wound, an unnoticed infection, and suddenly life hangs in the balance. And yet sepsis remains dangerously overlooked in our healthcare systems. So delayed diagnosis, overwhelmed wards, under-equipped frontline workers, these failures cost lives, and it's a life every 2.8 seconds. Unchecked, sepsis fuels drug resistance, weakens pandemic readiness, and unravels global health gains. So I am calling on ministers, parliamentarians, and global health leaders that are here today and tomorrow to say that your leadership can turn silence into action. If we embed sepsis in every health plan, equip our nurses, midwives, community health workers with the tools and training they need to save lives, and to say that this is not about charity, but about solidarity. And if we reference the Global Sepsis Agenda 2030, this gives us the roadmap, and we need the will to act. So in closing, in this 3-minute gap that I have to get my message across, for my dad and for this continent, the silence around sepsis is absolutely deadly. And across Africa, midwives, scientists, survivors are rising to say Africa is ready, and the time for sepsis action is now. So thank you for the opportunity, and thank you for allowing me to speak.
Thank you, Robyn. Thanks for the work that you're doing. I remember traveling to Uganda with Tex Kasoon several years ago and really seeing what I can only describe as an assembly line of death as young children were wrapped up and given to their loved ones. And it was really just a heartbreaking experience. And I'm just, thank you for bringing it forward and turning silence into action, I think is a key message. Last but certainly not least, Amy Campbell. Hi, Amy. Amy is a nurse, educator, leader, and lifelong learner with over 22 years of nursing experience. She uses her passion for nursing to drive excellence and positively impact others. As a nurse educator at Pitt Community College, Amy was recognized for teaching excellence and was a finalist for North Carolina Community College Teachers. Now, as an associate clinical professor at East Carolina University College of Nursing, Amy teaches quality safety, health policy, and healthcare finance courses to upper-level master's students and mentors nursing honors students. Amy, over to you.
All right. Thank you so much for the opportunity to be here today. Been a nurse for 25 years. The last 15 years of that, I've been at ECU Health in a quality nurse specialist role, along with teaching at East Carolina University. I joke that I'm a double agent, but it's a wonderful opportunity to be able to share my passions. And one of my biggest passions is sepsis. And that really started as a child. I had sepsis as a child. It was unrecognized. Fortunately, we got antibiotics quickly. It came from a sinus infection. And then later on, I start teaching, I start working at the hospital, and then end up finding that I'm in sepsis, that I'm working on that with the sepsis core measures. And I think, Robyn, everything you said was so beautifully put. And, sepsis doesn't discriminate, and neither can we. And we really have to think about our communities and how do we start saying sepsis early. And I heard some other panelists saying this, is we cannot overlook people when they come in and they tell us, hey, I don't feel quite right. They give us these vague symptoms, and we really have to try to just not dismiss it. They could very well be septic. And I heard this story, and this really put it into reality for me. We talk about prevention. We want you to take care of your chronic diseases, get your vaccines, take care of yourself so you don't end up with sepsis. But sometimes sepsis can come to you. You could be walking along the beach, step on a shell, cut your foot, and then you're not feeling very well. By lunchtime, not quite right. By dinner, you're in our emergency room. By midnight, you're in the ICU. By 5 a.m., we're talking about amputations. That sounds crazy, but I've actually seen a very similar story happen. That is how fast sepsis can take over the body. That's how fastest you can have that immune response. And we can't pick up every shell on the beach. I wish we could. We can't prevent all those things from happening. But we do need to recognize when someone is on those sepsis highways. And I think we miss it. We miss it sometimes with our vital signs. We miss it with our elderly who come in and they say they have they're cold sepsis. They don't have a temperature. We just think, oh, they're tired or they have a virus. So actually, when I was up in New York with the Global Sepsis Alliance with the UN in New York, my son was not feeling very well. He had a virus. Well, long story short, if you can believe it, when I got home, he ended up developing sepsis. And I'm someone around sepsis all the time. And it did look like a respiratory virus. And within a few hours, he went into acute respiratory distress syndrome. We had a lot going on with him. He had a very normal pneumonia that ended up becoming sepsis. So we don't hold up signs there saying we're septic. So how do we become better at this? We need innovation. We need research. We need resources. Our wards are full. Our EDs are full. It's easy for me sometimes as an armchair quarterback to say, oh, we should have recognized that. We should have seen that. When you have so many other things going on, you've got to think about system solutions. So I'm very much here as an advocate. I'm very passionate about this. I feel like that everyone, no matter where they are in the world, should be recognized. They are septic. Let's get the antibiotics started and let's treat them effectively. Again, thank you so much for this opportunity.
Thank you, Amy. And Elena, we have a question from the audience. What advice would you give to a new sepsis survivor group as to setting priorities for action? Informing the general public, concentrating on the healthcare sector, what would be your advice?
Yeah, my view is that there is like a pyramid. Like below, we have personal stories, and we want to make a change. So we have to reach decision makers. And it's very hard from a patient singular point of view. So you need to be related to a bigger or patient organization. It can be regional, it can be national. For instance, in Europe, we have national sepsis patient movement. We have European alliance that can represent your story at, for instance, the parliament. So that's what we have done last year in the Palais de Iéna in Paris, is to represent real testimonies, real patient stories. So we are listening and we want to make a change. So it's true, Tom, that we have to raise awareness about the symptoms, about the signs, but sometimes they are not specific, and they are, you can think it's another non-potentially deadly disease, for instance, the flu, or for instance, a hangover in the teenagers. So we have to make sure that the signs, the symptoms are spread in brochures and leaflets. But for us, as patient organization representative, the most important thing is to knock on the door and to reach out decision makers so they understand the gravity of the illness and they help us to make a change. I hope that I answered to your question.
Yeah, I think so. I think, there are lots of ways to do things that have impact, and it takes really, truly takes a village. And, some can do it at a global scale, some can do it at a local scale, and it's all important.
Indeed.
James, turning to you, what are some of the, challenges you see in the work you're doing? I mean, you have a unique voice as a medical professional, but we've heard from many medical professionals who have had trouble getting the care that they need, even as nurses or docs, as patients. And, what do you see some of the biggest challenges you've had in, getting to where you want to go, to have the impact that you want to have?
Well, I would say there's still I'll speak for the Caribbean and the 20 or 30 countries there are in this part of the world. There is still a lack of awareness. Sounds weird. Lack of awareness of sepsis and how fast it can come on. So I put in the chat, I have a 5-year-old grandson who 1 year after I had my episode, he came home with a sore throat. The school nurse had sent him home. He wasn't feeling very well, like Amy said, and wasn't taking him very seriously at first, but then he didn't want to get up. Now, it turns out, fortunately, his dad is a pediatrician. He came home and he saw, oh my God, couldn't feel his pulse, get him into hospital. And the nurses at first were, oh, he'll get over this. They were a little bit dismissive. It was when somebody tried to measure his blood pressure and they took some vital signs, they realized this kid is really sick. And he was in the pediatric intensive care unit 1 hour after that and intubated and went through 2 rounds of intubation and, has survived with no sequelae. He remained for about 2-3 months after, he was very psychologically affected. So he did not want to go back to school because school and a sore throat at school is where this had started. So it took a long time. The post-traumatic stress went on for a long time, as I think it was somebody else mentioned earlier on in the call, that the mental aspect of it went on for a long time. So when you ask me, I think awareness of this at all levels of the health system, both in undergraduate training and postgraduate continuing medical education, continuing professional development programs, think about sepsis, because often you don't have much time before the person is dead, not to be over dramatic. In my case, it went on for days. I got sicker and sicker. In my grandson's case, it went from start to ICU in 12 hours. So I think awareness raising is one. At the policy level, for the Caribbean, you've got 30 odd countries here, 40 million people. This is not yet a policy position of the ministers of government. in the region. It's something that I know Tex has been working towards, and we need to push for that it gets a bit more prominence and into the thinking and planning of emergency services and family care, family medicine. So those would be my two, awareness raising at all levels and policy level and continuing medical education.
Yeah, and that continuum of care, you talk about a school nurse, that's there was an opportunity there for that nurse to suspect sepsis and perhaps accelerate the treatment continuum. But fortunately, there was a pediatrician at home, and I'm glad he's doing okay. But these, the after effects are worthy of noting. More than half of survivors have significant ongoing challenges, which preclude them from returning to school, as your grandson experienced, returning to work. So a big issue, obviously early diagnosis, and then if, for survivorship, big issues there that need to be addressed. Priskil, I'd like to hear more about your experience and the work that you're doing and kind of how you're expressing your voice. Are you doing it singly? Have you joined up with an organization to be part of? And how much has your kind of post-sepsis experience entered into the way that you try to educate others?
Yeah, thank you, sir. In my place, in Mizoram, in my home state in India, is a remote, economically backward area of India, inhabited by majority tribal population. We do not have big hospitals and adequate number of healthcare specialists. We do not have advanced equipment in our hospital also, as they all depend on government funding. So for specialized treatment, we have to go to mainland India, and this becomes a burden financially for the majority population, basically for small farmers only. And the present government is in the process of overhauling the existing healthcare system, and I do hope that the new healthcare policy will user in better conditions and improve the overall healthcare system here in Mizoram. As I was in hospital, Kolkata Medica Super Specialty Hospital, and that day I was only 19 years old, and I was suffer from SLE, as I said before, and followed by sepsis. Sepsis with multiple organ system failure, like a kidney failure and heart failure and such and such. So I need to fight for this very much to survive and to be and being able to reach in this level with this level. So and one thing I need to raise my voice for making hope to all the patients who are suffering from sepsis. If we are having a great medical treatment or medical team, we can survive it, as well as we should not give up. We should try our best to survive it. That's all I can say. Am I answering your question?
Yes, you are. Thank you. Thank you. And we have a question from the audience for Amy. When you have all these competing priorities, both administrative and clinical, how do you keep sepsis at the forefront?
That's a great question. I think it's telling the stories. We are not just a data point. When you put a graph in front of a stakeholder or a leader, which our leaders here are very passionate about sepsis. Sepsis is a priority, and we are trying, to make that connection. But when you look at that data point or you look at that graph, we talk about those data points. We give them names. We tell stories. And we also do share our failures. We meet monthly and we talk about our cases that we feel like we did not do the care we should have given. And we follow up with that physician or we follow up with that nurse in a very non-punitive way. And we say, hey, this was an opportunity where we missed those vital signs. And someone mentioned that earlier, talking about their grandson and the blood pressure being low. There's a lot of great tests out there right now for sepsis on early identification. But we also miss some of the low-hanging fruit with just our vital signs. When the vital signs and the blood pressure is starting to go down and you have a possibility of infection, of knowing the person could be in septic shock. I think keeping it a priority is understanding how you're on the data, looking at it every single day. And not everything can be a priority when you're in the hospital system or when you're at 9 hospitals. So I think you've got to look at what do you want to focus on. And sepsis is one of our imperatives along with mortality. And so we know that's something that we're going to be focusing on and looking at what is the data? What are the facts that I want to put in front of my leaders that's going to really help drive the behaviors I want to change? And I think that's something in quality we've worked on, is trying to figure out what's the story we want to tell when we only have 5 or 10 minutes, and how do we share the correct data? What are our key performance indicators that go beyond the SEP1 core measure, which is what we use in the United States? That's our bundle, the 3 and 6 hour bundle. That is great, but that's just one piece of it. We also want to look at how long did they sit in the lobby at the ED? How long did it take us to collect the urine? How long did it take us to get into the room? So we can kind of see what the trajectory of that patient is. So for us, I think it all ties back to the patient. When everything is a priority, I think telling those stories and having a dedicated team that focus just on sepsis. If you're trying to take it piecemeal, one person here, one person here, that's going to be very difficult. But I think when you have a sepsis team at the hospital that can go from when they are on the EMS all the way to post-sepsis discharge, can be calling them and following up with them, that's going to be the ultimate best plan of care for the patient. I hope I answered that.
Yeah, Amy, I have a bit of a follow-up, because the U.S. is fairly unique, I think, in that, healthcare is a business here, and how important is making that financial case. We all want to save lives, I assume, but these folks are running businesses in the hospitals, right? And they act like business people, and how important is making the financial case that better care is better business.
Right, we're tied to public reports. There's public reporting. Our stats and our statistics are put out there. The patients are our consumers. We also have SEP1 that is tied to value-based purchasing. So it's extremely important to us. We want the patient to do well, but we also need the funding to keep our hospitals open. So we're trying to balance that right now in transparency of how can we do better with our SEP1 core measure. When you're trying to do everything within a 3-hour window, and even with my own son, who I felt like got excellent care, the first few hours we were trying to establish an airway on him and try to figure out what was going on with him. So sometimes our diagnostics delay us from starting our treatment plan, because we're trying to determine, is the patient having an MI? Are they in DKA? There's so many things that can look like sepsis that are not sepsis. So we're very aware of it, and we want at ECU Health, we want to be the best. Like, we're trying, to look at high performers and do these different collaboratives and this networking, so we can share those ideas, share what others are doing and innovation, so we can bring it back home to us.
That's great. Thank you. Robyn, to another part of the world, such a big problem. And, where do you focus your attention? Is it on infection prevention, which we know infection prevention is sepsis prevention? Is it water? Is it food? Is it early detection? Is it, diagnostics, therapeutics? How do you prioritize your work in a resource limited environment like that?
Great question, Tom. Back to basics in resource limited settings. So if you can get the basics right in basic infection prevention control, understanding symptoms, knowing how to deal with them, and dealing with them as quickly as possible. I mean, we should be dealing with sepsis as we deal with heart failure, immediate response. So but let's get back to basics in resource limited settings.
Yeah, and Graham, I'm really interested in your background and interest in the environment and environmental health, and the fact that climate change is happening, and it's certainly impacting, from our vantage point in the U.S., my vantage point in the U.S., we're seeing warmer temperatures are causing the waters to be more dangerous for anyone with open wounds. James, you spoke about that. More dengue fever, more fungal infections and things like that. Is your interest kind of bringing those two things together as you move into a career?
Well, honestly, the biggest thing that I took away with this in environmental science, is just advocacy in general. Like I know advocacy is a big part of environmental science, and that's how you kind of push, some sort of, incentive, push some sort of whatever, you're trying to get across. So that's kind of why I reached out to the Global Sepsis Alliance, because I wanted to be able to advocate myself for a public health issue such as sepsis. Um, yeah, my interest kind of falls more in sustainable business, so it's kind of fighting climate change at the business level. But I've looked into a little bit of microplastics and kind of how they're microplastics in the waterways. They're everywhere. We just don't see them. And I've done a little bit of research on that. And so I'm kind of opening questions up to like, do you think that that could directly cause sepsis? Like, what if it gets so bad one day that this becomes a direct issue? Does that make sense?
Absolutely. I think another challenge that we're all facing, regardless of the country or the resources available, is antimicrobial resistance. And in a number of ways, one is that, if we don't have antimicrobials that work, we'll obviously be less able to fight the infections that can cascade to sepsis. But it also is causing a lot of friction in the care continuum. Do I wait until I have more certainty about this being a bacterial infection, let's say, before I start a broad spectrum antibiotic, so I don't overuse these, versus understanding how quickly sepsis can cascade? And maybe with that kind of question about that friction, and we've been very, very aggressive in saying it's AMR is our issue, it's a sepsis issue, and we're for the appropriate timely use of antibiotics. And get the first dose on board. The worst thing that happens is we find out it was unnecessary. But better that than waiting. James, I'll start with you.
So if I have on my rational public health physician hat, I would argue being evidence-informed in your treatment and being cautious in the use of the antibiotics. As a patient, give me the antibiotics because that may save my life. Give me early. As soon as you have any suspicion that there's a septic process going on. Where I live, I see severe dengue, which is a viral disease, is very easily mixed up with like pneumococcal pneumonia, and you can be going down very fast, or meningococcemia. And you don't even get back the labs. You just see a really sick patient, give them the antibiotic. So with my patient hat on, I would advocate for early treatment. And worry, if, as you just said, if it's wrong, the most you do is you've given one dose unnecessarily.
Yeah, hypothetically, we want to be discriminating, right? But if it's your child or you in that emergency department, it's give it to me now, and I'll worry about the resistance later. Amy, same question.
Yeah, I agree. I think it is a balance. One of the things we have done is tried to partner with our infectious disease doctors here, and we have an antibiotic, we have a stewardship committee that actually looks at cases and gives us advice. And I think it's really looking at where are they at to me on the sepsis highway. You've met those Sears criteria. You've got the heart rate going up, the respiratory rates going up, or you've got the white count. You have things that are looking like infection, new organ dysfunction. I think you've got to start talking about antibiotics. Let's do blood cultures and let's get antibiotics. I feel the same way. I don't know the first dose, just getting on board and started is going to hurt anything. But I do think there is some caution there. We have to look at both. But to me, it's leaning into your experts, knowing the people, having different people to look at the cases, have an ID to look to see. And you can't do that on every single case that comes to the ED. But I do think it's something we should consider. Someone once asked me, they said, so Amy, are you telling me I've got to get blood cultures on everybody that has a urinary tract infection? I'm like, no, they can get PO antibiotics. You don't have to do that. Not everybody's on this. They might have sepsis, but they're not severe sepsis, septic shock. I think when you look at mortality and you look at how important getting those antibiotics started within the first 3 hours that we're recognizing that they are severe sepsis, I think it's worth giving the antibiotics.
Thank you for that. Elena, I'm curious, coming from, meningitis perspective, I think a lot of our work depends on us connecting the dots between infections and sepsis. Yeah, I remember having meetings where folks said, well, we're not really interested in sepsis. We're interested in healthcare associated infections. And I banged my head against the wall and realized we weren't communicating well enough, that we need to do a better job connecting the dots between infections and why they are dangerous. And it's, the potential cascade to sepsis. So, and so with COVID, that was almost a helpful tragedy in that, people became more aware of the dangers of a viral infection and the connection to sepsis. Has that entered into your work with meningitis, is kind of having a challenge connecting, well, how are meningitis and sepsis related? Is there, a way to communicate that you've found effective?
Well, when we reach our sepsis patients, they do not like to be linked to the meningitis survivors, because they say that we were affected by a bacteria that went directly to our bloodstreams. So don't tell us about this meningitis stuff. So that's why COMO, which stands for Confederation of Meningitis Organizations, or in Spain, Asociación Española de Meningitis, we always add "and sepsis," because there is a difference. It's very technical. I know doctors are very familiar, but even patients, they feel, that I didn't have meningitis, I was affected by sepsis. So all our brochures, leaflets, and raising awareness of the disease aims to differentiate sepsis to meningitis, because it's different. And although we, in Europe at least, I don't know about the US, we stand for any of their rights, their difficult situation, it's good to separate what is sepsis compared to meningitis, which is only when the disease affects your meninge. So anyway, at the end, we talk about prevention and we raise awareness about the symptoms. So it's good to gather all this information and to separate the different diseases. It's a task, but it's good to be here, for instance, today, talking about meningitis, and it's good for sepsis to talk about the other disease. I'm so proud to share with you that in Brussels, we will launch another summit to knock on doors and to our MEPs in Europe to to inform them about this disease, so they understand the gravity and they start to implement national plans, which is a way to eradicate, it's not a word, but at least to defeat this disease. And in Spain, I'm so proud to announce also that October the 6th, we will launch the first Congress about sepsis and meningitis.
That's fantastic. Thank you so much. Priskil, I have a question for you about the care you received, from the time you went from being well to sick. Is there anything that you think could have been done better in terms of how you were diagnosed and treated and your discharge and post hospitalization experience went?
Yeah, yes, sir. When I was sick, I have got so many treatment, so many medicines or diagnostic something. I'm not much sure because I'm just only the patient. But I want. When I stay in the hospital, I have so but the medical team have worked so hard, and I have received so many care, and I stayed in the hospital around almost half year, and I have received so many care, and they are all hospital also very nice. I stay in the medical super specialty hospital at Kolkata, along with the doctor. I need to mention his name, Dr. Savan Panja. Yeah, he's very good to me, along with his team. That's all I know I can say. Thank you, sir.
Yeah, and I'll put that same question to Graham about your healthcare experience. I know there were some challenges.
Yeah, to relate back to environmental science too, like it's just a public health concern for me knowing that there's all of this, the front line needs to be the ones who are properly trained to identify sepsis. Unfortunately, it's proper education, I guess, at the end of the day. I guess it really depends on where each individual frontline person comes from. I'm sure the nurse practitioner wasn't properly trained enough, so I can't even blame her for misdiagnosing me. But I truthfully believe that it just comes with proper education and more proper training when it comes leading up to becoming a nurse or becoming a doctor or et cetera.
Yeah, thank you. Yeah, I think that early education opportunity is huge and largely untapped at this point, I think. For Amy, any advice just from the audience, any advice on breaking through pushback from providers? As a sepsis coordinator, I hear from my ED physicians, the bundle doesn't work. Very frustrating.
I think you have to put, that we have this saying, in God we trust, everyone else we bring data. So I think for us, it's showing when we use the order set, we see a decrease in our mortality. We sometimes with our core measure, it is frustrating when they miss the lactic acid by 1 point or 2 points. And that are seconds. I don't worry about those. And I tell them that's low hanging fruit. I want to talk about why it took us 12 hours, 8 hours. What could we have done differently here? I think you have to personalize it. And what we do is when someone doesn't pass the core measure, we don't do the 3 and 6 hour bundle. We review that case in our committee, and then we send an email for that physician for follow up. And I think that's very helpful. And when it's a mortality, we send that as well, unfortunately. And those cases go in, they're reviewed. And I think it's just connecting. There is a knowledge gap with understanding the why of with the core measure and what exactly is in the core measure and when they'll fail. And so I think for us, it's all about data and facts. The stories are great. They help a lot, but showing those data. And even when we've showed physician, what is your compliance with the core measure? That's helped some because they're all competitive. They want to do well. They want to see that they're 80 to 90% compared to someone else. But I think you just keep knocking and you just keep the data in front of them. I think at the end of the day, we all want to do the right thing.
Yeah, and a follow-up, I think a lot of focus is on the hospital setting, yet we know, at least in the US, 87% of cases begin in the community.
Right.
And that time to treatment, that time to presentation at the emergency department is critical. And how much, is your institution doing to educate the public and connect with home health and primary care, providers, nursing homes and families to know to get to you earlier so that you have a better chance of being successful?
Right. We've done a lot of community outreach. Not my specific department, but we do have departments that do community health. And we actually had a big grant in Edgecombe County where they saw a 25% decrease with their work. And it was mostly education. I participated in some of it, and it was just going to the clinics. And you know who I talked to the most were the secretaries and the people answering the phone. And this is why. I call up and I say, I'm not feeling very well, and I give vague symptoms, and they say, well, the doctor will see you in 3 or 4 days. And I taught them, you need to ask more questions. Do they have a chronic condition? What have their vital signs been? Have they taken their temperature? Are they saying things like, I can't get out of bed? I'm not drinking very much. Do they have a toothache, an earache, anything that could sound like an infection? They need to be seen immediately. And when I've gone to like a council on aging and I've talked to my seniors, I teach them the word sepsis. I said, I want you to use this word. I think I may be septic. And also, do not wait until you're super sick to come to the ED. Try to take care of things early. And that is one of our barriers, is access to care. Where I currently am in Greenville, compared to some of our other counties, we have trouble with access to care. And so what do we do about those that do have an earache, or they do have something that's very simple, or even a toothache, but they don't take care of it and the abscess tooth becomes septic? So I think, we have been trying, we could do more. I think as our group, my team of sepsis superstars, we always feel like we could do even more than what we're doing. And we're looking at different avenues to do that. But community awareness of how sepsis does not discriminate, is not in the elderly. It can happen in a child. It can happen from anything that you can get that bacteria into the bloodstream. So just, you can go get a pedicure and end up with sepsis, which is crazy to think about. But I think just that awareness and teaching people sepsis, and if you own a clinic or you're a provider and you have a private practice, making sure your gatekeepers, your secretaries, the people who are answering the phones or making appointments, that they don't dismiss people and really investigate and have kind of a little questionnaire so they identify those septic patients. Because that's the worst thing, is when someone shows up at the ED and they say, well, I called and they said to come back in 3 days or come to the ED, and by the time we see them, they're already in septic shock.
Well, thank you for that. That's great. James, same question in the Caribbean, in terms of, hospitals we hear are generally, saving more lives. Mortality is going down a little bit. But we need to pay attention to the morbidity associated with that life saved. But, going upstream, given how much of this is starting in the community, not in the hospital necessarily.
I think I would echo some of what Amy just was talking about, community awareness. I mean, for so many things, that is also true. And for the physicians and the physicians' gatekeepers, high index of suspicion and asking more probing questions. I mean, we're taught as in medical school, if somebody's had a fall, you ask them, did you lose consciousness? Because did you black out? Even momentarily, that's a sign of a pretty bad head injury, and so you need to go in. Somebody's fallen and they've damaged their leg, and you say, were you able to walk right away, or were you unable? Because if you're unable, that means a good chance you might actually have a fracture. If you were able to spring up and walk, maybe you didn't have a fracture. So I think those kinds of practical tips for providers, primary care providers, and for the community would be important. And that's what I was saying earlier. We really need more awareness about this. Where we are, very often the first person is going to be asked, we don't have the price barrier. Like, it's really shocked to me when I come to the States. You get sick and you go to the doctor. How are you going to pay for this? That's the first question. I'm not used to that where we are. People will see you. And the nurses are so important. They're the front line. And they've got to be trained to think about this more, have it more at the forefront of their minds. So I would say primary care, nurses, those are really, the pharmacist. A lot of people consult the pharmacist. I'm not feeling too well. What would you recommend? Pharmacists also need to probe a little bit more, but what do you mean you're not feeling so well? Along the lines that Amy was just talking about. Thank you.
Yeah, we've seen, in the US, we really focused on the continuum of care, including OBGYN, oncologists, even podiatrists we know have picked up cases of flesh-eating bacteria in their treatment. Chiropractors, school nurses, all are a potential early recognition point to start the care process. We're running up on time. It's been a really awesome conversation. Any closing remarks? Graham, I'm going to start with you because I was really taken by your comment about kind of invisible symptoms and survivorship. And, so many survivors do suffer invisibly. We know many have amputations, but many suffer silently. And can you speak to that a little bit and how we bring more awareness to the, kind of the unseen damage of sepsis?
Yeah, for sure. I think a good start is just advocacy. I think it goes right along with mental health, because mental health is a big thing that is just invisible diagnosis that nobody else knows of. And I kind of see it similar to that. While I physically had a crutch and people could see that, I don't understand why they were concerned with my day-to-day life. Why do they care that I have a crutch? I kind of I'm not sure the best way to go about it, but I know that this is definitely a start, just kind of bringing up the topic of invisible disabilities in general and how it can affect the day-to-day person who might have mental health disabilities or just physical disabilities that you may not be able to see.
Thanks, Graham. And Priskil, I'll turn to you next in our last round. Any thoughts or comments about kind of sepsis survivors and supporting the needs of our survivor communities?
In my communities, especially in Mizoram, we are very less who is suffering for sepsis. Unfortunately, I'm one of them only. We are very less especially Mizoram only. I don't know in other state or in India, there are many sufferings from sepsis. In that case, we need to make more awareness. We need to have a community along with these diseases. We have to arrange about the health facilities in some poor state in like Mizoram, some in Northeast like that, I think.
Great, thank you. Robyn, same question to you as we close up.
For me, in a resource limited setting, it is advocacy, it's knowledge, it's those frontline workers that have access to that individual from the get-go. And also family members, they need to understand what they're dealing with. For me, for my family, we didn't know what we were dealing with, and it was far too late. So the more we know, the more knowledge that's spread around, the more chance we have of survival.
Yeah, we really have to bang the drum. Someone said to me, we have to make sepsis famous.
Yeah, we
And,
do.
There was one question in the chat about use of celebrities, and I think we all acknowledge that that can be very powerful. And as more acknowledged that they actually did have sepsis, it wasn't just pneumonia. Val Kilmer, I'm waiting for that to come out that it was sepsis, because you don't really often die of pneumonia, right? It's usually to sepsis. So I think we'll be, hopefully that story will get told more completely. Elena, kind of survivors and survivor community, what can we do more to help that group?
As I said, it's hard to help an individual. As Robyn said, it's her father, Grandma or Prisk, it's their own story. But if we stay on that very particular state, we can't make a change. So you have to rely on a bigger patient association that will defend and represent your story at a national level, maybe. And then if you're in Europe, at a European level, and then, reach the MEPs to ask for a national plan to raise awareness about the disease. So they reach nurses, they reach the media, they reach the medical journal. We have been in the Lancet. Can you imagine that? Just a simple, very few patients representative. We were gathering in Paris, and that call to action was in the Lancet. So it's feasible. It happens. Never underestimate the power of a small group of patients. It's not my sentence. We all know that it comes from Margaret Mead. So yes, if you stay on your relatives, siblings, and the neighbor that your father died from sepsis, it's not enough. So to make it bigger and to raise awareness globally, you have to rely on your patient organization, association, and at a national level. I'm a profound advocate, and I truly believe in our power, because I have seen it works. They listen to us.
Yeah, I think it's a great message, and sometimes I think we get frustrated. We've been at this. Carl Flatley lost Aaron in 2002, and at that point in time, Microsoft didn't even have the word sepsis in its dictionary. It was a spell check error, and we've come a long way. But it's frustrating that we haven't made more progress. But you think back about Cancer Society and starting almost 80 years ago, or the American Heart Association starting 100 years ago, and it takes time, it takes persistence, but it takes time also, and we are making progress. Although I'm sure we would all like to make it faster. James, I started with you. I'm going to end with you.
Yeah, well, on this question, I think it's actually part of a broader issue about invisible illnesses. We have a daughter who has had some chronic pain problem for the last 5 or 6 years, and after lots of specialists and lots of money spent, we still don't know what's causing it. When she's going to the airport and she's in a wheelchair, people look at her and they make a judgment. She looks normal. Why is she occupying a wheelchair? Some old person who really needs it should be in that wheelchair. And sometimes they tell her that. So, the Bible says, judge not, lest ye be judged yourself. And maybe we need to have a little bit more sympathy, empathy in among people, that don't judge just by what somebody looks. They look okay, but they're not okay. And you have to respect that. So that is part of a bigger problem, I think, than just sepsis survivors. In the case of my grandson, there was this, it was close to 6 months that he was really trouble to get him to go to school, because school in his mind was associated with, and he would say, suppose I get it again, Opa, he calls me Opa, suppose I get it again if I go to school. So it took a lot of counseling to work with him, until little by little, now he's okay.
Yeah, the interesting experience we've seen that, sometimes support groups meet in hospitals, and it's the last place someone wants to go to talk about their experience in the hospital. And, I think we learned that that's not a good thing, not a good idea. Yeah, it should be in some other venue. So yeah, I'm reminded that today, Global Sepsis Alliance launched the Global Sepsis Survivors and Families Committee. Sure, if you haven't heard about that, you will. So that's very, very exciting. And I want to thank all of you. I learned a lot today and got very inspired, and I'm sure our audience did as well. And look forward to seeing all of you again. And thanks to Marvin and Miriam and the whole TEX and the whole GSA crew for putting this together and making sure that the patient voice was an important part of this conference. So thank you all. Hope you all have a great day.